Let's turn to tumor mutation burden. On our tweet chat, someone asked about that, and I think lots of people are wondering, should they be ordering it? And if so, how should they be using it in practice? Charu, I'll start with you here.
So I don't routinely get TMB at this point in time. We do our gene sequencing in-house, and TMB is not something that we are able to clinically make a decision on yet. I think it's cumbersome. You have to know which test to order, how to interpret the test that you order, and to apply it. I don't think there's any clear guidelines. I think PD-L1, we still can say, yes, there were trials driven based on PD-L1 expression. I just don't feel the same way about TMB. Now, I do think that it's a relevant biomarker for future clinical trials, and currently what we are doing in terms of patient selection in conjunction with other biomarkers as part of a clinical trial. So, I think TMB is very relevant. I just don't clinically use it routinely.
Now, Haas, I know you have a lot more experience and spend a lot of time thinking about this. So both what do you do and what would you recommend for the oncologist in practice?
Right. I mean, the second question is easier to answer. As long as we don't have a clear approval associating a specific treatment with survival advantage to TMB, I don't think you absolutely need to get TMB. So I think in the absence of a clear clinical indication, there's no need to do it. Our in-house panel, the new in-house panel, promises to give us TMB because we're switching to a bigger sample, bigger platform. So maybe we get that, but for now, if you send your molecular testing to companies that are out there, then you get TMB basically for free as part of the whole sequencing that you get your results back. So if you use one of these other entities, you get your TMB data back, and it's no extra charge for it, right? So it can be part of it. And right now we're getting that. So as part of my EGFR and everything else, I do get the TMB results back. But do I use it clinically? As I said, I've had a couple of examples of patients with negative PD-L1 and low TMB where I've had to have a discussion with the patient, or I'm in a second line or third line setting and I'm looking for a clinical trial, somebody who's been through IO. I do look at the TMB to say, do I think this patient has a higher likelihood of responding to another immunotherapy or something to that effect? So I don't use it for everyday clinical practice, and I'm not saying that I use it to make a decision whether I should give chemo IO or IO to somebody, but I do look at that when I'm trying to decide subsequent lines of therapy and what I might be offering to the patients. I think TMB does have a lot of issues to overcome, kind of like what we were with the PD-L1 testing, and everybody had their own antibody and platform, and we needed Blueprint to sort of, tell us what these tests are. I think something like that is in progress for TMB, so we know that that work is being done. So I think before long, we'll have some way of sort of standardizing the TMB testing, which is absolutely needed. But as long as there is just PFS advantage, or maybe a little bit response advantage, and not OS, quoting somebody that we like, saying don't bring PFS to an OS fight, if you remember that. I think it's, I know it's yours. Yeah. I think it's hard to argue to use the biomarker in everyday clinical practice. So I think those obstacles have to be overcome for us to say TMB is going to be our everyday use. But I fully believe we're going to get to a multiplexing. I think we're going to be looking at TMB, PD-L1, and a couple of other markers within the next 2 to 5 years to decide who should really get IO and who should not get IO.
Do you think that, I think that potential for negatively selecting, that if someone is negative for PD-L1 and negative for PD-L1, that may be the patient who is especially unlikely to benefit. But do we want to know that? Will patients take that and say, okay, now I happily accept that I'm not going to get it? Or is this something that's going to be a tool used by payers as a barrier or requirement? Not that it would be wrong to actually do some kind of means testing to see that you could benefit. So how practically do you see it being implemented to support that concept of negatively selecting the patients least likely to benefit?
I think that's a major issue. If you can avoid the toxicities of these drugs, even though it's only 15% of patients who get really severe toxicities, look at all the randomized head-to-head to chemotherapy kind of thing in the second-line setting. That's still, these toxicities are real. These patients end up in the hospital sometimes because of these toxicities. So if you can select a patient population that's absolutely not going to benefit from IO, forget about just the finances. I mean, not that you can't, but let's just put that aside for a minute. Just from a toxicity point of view, I think it's very important. Moreover, it gives an opportunity to think about that patient population and say, okay, so what is it that biologically these patients are telling us, and what would be the better way of treating them? So it's a negative selection for the currently available IO crop of drugs that we have, but who knows down the road, maybe a new IDO would be perfect for this patient population, or a LAG-3 would be perfect for this patient population. So it opens up those sort of avenues that we haven't had explored so far. But I think a negative selection would be extremely helpful to me, not giving a drug that can cause a lot of side effects to a group of patients.
It would help you personalize that.
Absolutely.
So, do you see TMB as being specific for identifying patients more likely to benefit from Nivo or Nivo-IPI, or do you see this as being a marker of benefit from immunotherapy regardless of the specific agent?
I would say from Naya Rizvi's work, from other people at Memorial, we know it works for pembrolizumab also. So I think the currently available checkpoint inhibitors, the PD-1, PD-L1, the CTLA-4s that we have in the clinic now, we have a lot of retrospective data to suggest that PFS and response can be better in the TMB. So I think it's not just something for Ipi-Nivo. I think it is something that's applicable to what we're using right now. Now, again, is it going to be applicable to the OX40s or the CD73s or the LAGs? That information I don't have, and I'm sure we can generate that information. But it just does seem to be a little bit of an intrinsic tumor property that's telling you that I have a lot of mutations, and therefore that might be more meaningful when it comes to choosing an immunotherapy-based approach.
Let's look just a couple to 3 years ahead. Do you see TMB being a routinely used tool? And if so, do you see it as replacing PD-L1, being one component alongside of it, or even maybe being a bigger composite that may include gene expression profiling? Where do you see patient selection for immunotherapy and TMB in just a few years?
I think TMB is here to stay. There have been multiple studies that have shown that TMB can predict response to immunotherapy, not necessarily immune combination versus chemo, but just immunotherapy in general. It's an inherent property, as Haas said, of the tumor's heterogeneity or mutational burden to basically predict how many epitopes they have, how many antigens do they have, will they respond to immunotherapy. Do I think that I will be using it in the future as a sole marker? No. I don't think it will replace PD-L1 completely. I do think that we'll be looking at sort of like a panel. I think it'll be an immune panel, just like we order a gene sequencing panel to look for molecular alterations. I think we'll be ordering an immune panel. And wouldn't it be wonderful if we had, 5 or 10 or 15 things where we could come up with an immune score and say to the patient, I think you should get chemotherapy, or I think you should get LAG plus chemo. I think that's where we're headed, and it would be such a wonderful but complicated world.
Haas?
I agree.
Yeah.
I think multiplexing is the way to go, and I think that's where we're going to get to.
Complicated, though.
Yeah.